So I'm Dr. Estvold. I do family medicine / primary care here in Georgia. And kind of my quasi specialty that I fell into is LGBTQ medicine / transgender medicine. I'm still a resident. I'm in my second of 3 years. So I have one more year of training to go, and then I can fully be out in the world practicing my medicine. But I kind of created my own little niche here at AU because there was nobody kind of catering to the LGBTQ community. So that's what I do. I'm not a neurologist. I don't deal with a lot of Parkinson's patients. And so when I was asked to present and talk to you guys today, I was actually very intimidated because I had never actually thought about the intersection between Parkinson's disease and the LGBTQ community. Obviously it's there, but it's not something that I come into practice with in my everyday practice here. So let me talk to you about kind of what I'm thinking, and I'll tell you a little bit about what I do and a lot about LGBTQ medicine, because that's the majority of what I do. So I like to do a little icebreaker first when I talk to people, because actually I talk to a bunch of the different departments here at Augusta University and do this kind of like cultural competency medicine boot camp for the different departments here on how to effectively treat the LGBTQ community when they come in and they need service from you. So most of you already probably know these, and I know it's probably backwards on your screen. Didn't anticipate that, but I like to run through. Does everybody know what all of these letters stand for in the alphabet soup that is the LGBTQ community? I can't see people, so I'm going to assume that you know some of them, but I like to run through it because if you know, you know, and if you don't know, well, you're going to learn something new. Right, so L stands for lesbian. Most of us know that. That's usually female identifying people. G for gay. That's not just men who sleep with men, but people who identify as gay. B for bisexual. T for transgender. Q, there's two of them. First one is questioning. Second one is queer. Okay. I stands for intersex. The A's get a little confusing as well. A stands for asexual. Okay, so we can dive into that in a little bit. And then the other A stands for ally. Okay, so that's everyone who doesn't identify as queer. And then we have P for pansexual. This looks really backwards as it was written, but it's actually 2S. And I like to really highlight that one. That means, or that stands for two-spirit, which is more akin to a Native American form of thinking about gender identities. And it's not just does not mean LGBTQ to them. It actually means an amalgamation of several spirits inside one body that are male, female, and different. So that's a really cool one to highlight. And then plus adds on as everything else, because there's over 35 different gender identities out there, and people identify all along that spectrum. So if you can think of it not just as LGBTQ or LGBTQ+, that's a whole spectrum of gender identities depending on how people identify. That's what we see in everyday patients who come and see me. So what are we going to talk about today? I'm going to do a little tiny bit of medicine. I know this isn't like a very medicine forward conversation, but people may be wondering, oh, Dr. Estvold, like you're an LGBTQ doctor. Like, what does that mean exactly? And it means that LGBTQ people need doctors as well. And you don't treat them any way different. Okay, so we're all human beings. All human beings need healthcare, and they need access to healthcare, and they need to be able to be treated when they're sick. So some things that I like to focus on in my practice, I'll kind of break it down for you. Might be a little bit interesting. So in the lesbian community, I have lesbian patients who come and see me. Oftentimes they don't have super consistent care unless they have great healthcare or healthcare insurance. And we'll get into that barrier in a little bit. But one thing I have to be really important about with my lesbian identifying patients is that they're in an increased risk for heart disease. And there's actually a big study that came out by the American Heart Association that showed that due to secondary effects such as metabolic disease and obesity, it puts these women at much greater risk for heart disease and much greater risk for obesity. So I have to screen their lipid panel to make sure there's not too much cholesterol in their blood. I have to counsel them more about exercise, diet, and how to make a healthier lifestyle so that we don't let so that their heart disease doesn't become the actual thing that kills them. Next up, I have the Gs, the gays. That's also men who have sex with men, but there's a distinction there because not every male who has sex with men identifies as gay and vice versa. But one thing in that population that I have to be a little bit more cognizant of is that they're at much higher risk for STIs. So I'm going to do an STI screening on almost everyone. We're at a much greater risk for HIV. We know this historically from the big HIV epidemic from the 80s and 90s. And then it's still an ongoing worldwide epidemic that we're still treating. So all of my patients, I'm going to screen them at some point for HIV, regardless of risk factors. But then if they have increased risk factors, we're going to do more screening. And that segues right into PrEP, pre-exposure prophylaxis. And so that is your once daily pill that protects you from HIV. And so it's my goal to get as many people who are high risk on PrEP as possible. I don't know if you've heard of it or not. The two main PrEP sources are Truvada, which has been around for over a decade, and Descovy, which has been around for under a decade. Almost the same identical pill, but it's a once daily pill that you're going to take to protect yourself to guard against HIV. Now, you always use PrEP with condoms, right? Because it's not going to protect you from STIs or other infections and stuff. But it's a great pill to get everybody on. And right now, only about 25 to 35% of the MSM community is actually on PrEP, when it's upwards of 98 to 100%, 98 to 99% effective. So that's a huge push that I do in my clinic. Next, I have bisexual identifying patients who will come and see me, and you treat them like anybody else. But oftentimes that's a very important stigma that people have with bisexual people, is they say, oh, it's just a phase. It's not a real gender identity. You know, they're just confused. It's not true. They're not confused. It's an actual gender orientation, and they're at an extreme risk for depression. So that's one of the really interesting things. You'll find that in the literature, that their depression rate is much higher than the rest of the LGBTQ community. And so I'm always screening them for depression. I'm doing a PHQ-9 screen where I ask them 9 questions about the depression and see how they rank on that scale. And then I usually link them either with a behavioral health specialist, or we start talking about different drugs that they might need to help with their depression or anxiety, because they usually go hand in hand. And then the transgender community. So this is a large part of my practice. And mostly it's the hormone replacement therapy. It's actually transitioning people from one gender to the next. And this is something, like I said, I kind of fell into it about 3 years ago, and I had a really great mentor, and I just really picked up on it. And in the South, not a lot of people do transgender medicine at all. And so the fact that there's just a few people at my university here who do it really makes us popular with the community. And we have people who travel all the way up to 6 hours to come and see us for their hormone therapy. The cool thing about that is that when you transition someone, it's a 3 to 4 year process. It's a second puberty. So I get to see these patients very consistently over a 3 to 4 year period, which means I'm not just giving them hormones, I'm screening them for all of their regular screenings that they need. I'm giving them all of their regular healthcare that they need. I'm, checking them for depression. I'm checking them all of their routine labs. So that's a really cool thing that I get to do. Speaking of the labs for transgender people, they actually are at an increased risk for having hypercholesterolemia or increased cholesterol. They're at an increased risk for diabetes just from being on such a regular amount of hormones consistently for 3 to 4 years. So that's something I have to also be really cognizant of and do proper counseling on and proper screening for as well. Now, the screenings are also really important for transgender people. A lot of times my colleagues who aren't used to working with the LGBT community will have a transgender patient and they have no idea what to do. Like I'll literally get text messages and say, hey, I have a transgender patient. Do you want to come see them? And I'm like, well, yeah, I'd love to, but you can see them and you can still give excellent care. This is me typing. Because they get so freaked out for a couple of things. Is a lot of people are so afraid to use proper pronouns or even ask someone what their proper pronouns are. I can see on the bottoms of some of your guys' screens, like you list your pronouns out. And I think that's awesome. Because that kind of helps break the ice on just asking someone. But I tell all of my colleagues, just ask them. Ask what your pronouns are and then use them throughout the visit. And if you can't remember, you put it up on your note that you're typing at the computer, because we all use the computers, in super large lettering. And that's actually been able to help a lot. But I also like to have my colleagues do proper screenings on their transgender patients. So if there's a cervix and you're over 21, they need to get a pap smear at some point, okay? If they have breast tissue, they need to have a breast exam at some point, okay? If there's a prostate, it needs to be checked at some point. So we need to be cognizant that these are still human bodies that need to be treated like human bodies. So we'll get into that's kind of like a small overview of what I do. But I love treating this community. They're some of my most fun patients. Interestingly enough, I have maybe one Parkinson's patient, and that's mostly because I work at an academic center, so they all go over to neurology anyways. And so most of my LGBTQ patients are young. They're in their 20s, 30s. My oldest two transgender patients are 65 and 69, and they're actively transitioning, which is really cool because they came out later in life and realized that they can actually do something to help with their gender dysphoria, and that's something I can help with. But one thing that I like to do for everybody in this community, LGBTQ plus IAAQQ, Two-Spirit, is you screen everyone for depression. And that's super important. About half of my work now is dealing with depression in this community and screening them for depression, because behavioral health and mental health is such a big part of this community, and this community is such a high risk for developing depression. So like I mentioned earlier, for if anyone's in healthcare, I do a PHQ-9, which is a basic depression screen, and then I go from there. Unfortunately, linking them to a behavioral health specialist, like a psychologist or a psychiatrist, is difficult in this day and age, right? They're very overwhelmed right now because of COVID, and because mental health is so prevalent in our society right now, a lot of those specialists are completely overwhelmed. So we as primary care docs have to do a lot of the mental health work ourselves. And so we have to become really proficient in what kind of antidepressants we're prescribing, if they're working, if we need to switch them to something else. And then plus other therapy modalities that aren't just giving a pill, because all medication comes with side effects. We don't want to just give pills to people. So that's a big thing of what I do. Let's talk about barriers to care. So I know that was touched on earlier in one of the workshops, but that's such a big part of healthcare in general, and especially not having healthcare in general. And this community is at risk for not having healthcare. One of my clinics that I do is a free clinic. It's a free transgender clinic here in Georgia for anyone who does not have insurance, so they can't afford healthcare. And I think we have some sort of grant / like really great fundraising where we're able to pay for all of their labs. We help people with transportation fees, so like giving them gas cards and stuff so they can come to clinic. And we do a lot of our stuff electronically. We even offer telehealth visits if they're just too far away or they just can't make it in. And that's so important because a lot of people don't have healthcare because they don't have a good job that offers them healthcare. That's the number one way we get healthcare, or they haven't married into healthcare. And I hate that I have to say it that way, but oftentimes people get healthcare through their spouse because their spouse has a job that will provide it for both of them. And so this community, if they don't have either of those two options, what are they going to do? Urgent care is not going to treat all of your things. You can't use urgent care as primary care. You can't use an ER as primary care, right? Because that's just a get in and get out, fix the problem right then and there. They're not going to fix your diabetes. So oftentimes these problems will go unchecked for years. And so it's really important for us to get people linked with good healthcare. Another barrier to good care is provider knowledge. So kind of like I touched on earlier, you go and you see a healthcare provider and they see that you're an LGBTQ person and they shut down mentally because they don't know how to integrate that into their practice, which is really unfortunate because it's not much different. So a lot of what I do is just, I do like a big presentation to the other specialists, be like, this is how you just do normal screening for people, normal routine screenings for like skin cancer, for heart disease, for diabetes, for high blood pressure. All of those still count, and you can still give those to your people. Oftentimes though, I'll see like a transgender patient who will transition from seeing a different provider to have finally found me, which is really great. And that other provider has clearly had zero idea how to transition them and put them on proper hormones so that they can transition to their other gender. And I'll see these like crazy labs that make zero sense to me, and they've been on hormones for years, just kind of just ricocheting through their body. That's really tough because these providers haven't just taken the time to do the proper research. We as doctors know that if we don't know the answer, we have to look it up and we have to find the correct answer. And a lot of providers don't take that time to learn about transgender medicine, to learn about LGBTQ medicine. And unfortunately, these patients don't get great care because of it. I already touched on proper screenings, so we can skip that one. So kind of like, what can you do? How can we break down these barriers? I don't know if you guys have noticed my badge tag. but like one, there's rainbows everywhere. And that helps. So like I have this little rainbow pin that has been super helpful, because when I see people down in the ER, you wouldn't believe how many patients have said, or they've noticed it and they'll say like, I like your pin, you know, and it's kind of like, oh, they know that I know that they know. And so they automatically feel more comfortable now. And then I can ask them those questions like, who's your partner? Are you sexually active? Are they cisgender or transgender? Like, what kind of sexual activity are you having? And I can better provide more tailored care for you. The other really cool thing we did here at AU is, I don't know if you can see this little rainbow poking out here, but we invented, and by we, I mean I invented this badge tag that sticks, kind of pokes, it's meant to poke out from behind your other badges, because we have way too many, but it's a great identifier for people to let you, so that other people know that you are a safe space. And so I'll have patients in the hospital or in the ER or in clinic who will see the rainbow and they'll say something, they'll be like, oh, I like your badge. And it makes, like I said, it provides a safe space for them that they can kind of let down their guard and be more honest and upfront about what kind of healthcare they need. We took this one step further, and I broke it down by kind of the most basic gender types. There's, you know, for the lesbian, gay, bisexual, and transgender community, and what screenings physicians should be doing and what labs they should be ordering. So that if my colleagues, again, they blank, all they have to do is say, oh, I have a bisexual patient in front of me, I should do a PHQ-9 screen, and I should order basic labs. It's all right here. And then the back side of it is all for transgender resources. So they can look at it and say like, oh, literally it's like step one, ask what pronouns they use. And then it gives examples of pronouns in case you blanked on your grammar. So you can do that. And then it tells like what screening guidelines to use. If they're on hormone therapy, what labs to order and what hormones to renew. Because it would be useless if one of my patients saw one of my colleagues for like an HRT visit and the colleague did nothing. That's a waste of the appointment for the patient and for them. And then also at the very bottom, it also lists like other resources. So if you don't trust the badge, you can say, oh, I can go to glamma.org or the trevor.project.org, or I can refer the patients to there so they can help kind of answer some of their questions. I saw somebody just chatted, it popped up on my screen, where can you get these badges? We have them at Family Medicine and we have them in the hospital if you want to just like chat me on Messenger. And then if anybody else is like super interested in them, I can always mail them out. My department printed like literally like 1,000 and I mail them out to people who really want them. But it's a great tool. It's been very successful. And then we just pass them out to all the major departments at AU, and we pass them out to like nurses, to CNAs, and to front desk people. Anyone who is patient facing got a badge. And so like I always keep a stack on me and I just hand them out to like the nurses stations and stuff. And it's great because I've seen probably 40% of our employees here at the university with them on. And I'll comment, I'll be like, oh, I like your rainbow tag. And I've had people actually like break it down and explain to me exactly what it is, which is a really cool way to see if they understood how to use it. And it's gone over great. The other thing that I thought we should touch on is changes in medicine. So medicine is always evolving, it's always changing, but how about LGBTQ medicine in medicine? And so that's actually, it's having its moment a little bit right now. People are starting to become more cognizant that the LGBTQ population is still a very valid population that needs to finally get treatment instead of being stigmatized. Unfortunately, there still is a lot of discrimination, especially towards my transgender patients. Not so much here, but generally that's what the statistics show. And so it's important that we try and break down those stigma barriers, that we're very upfront and very welcoming is a better way to put it, that we've created safe spaces in our offices and our clinics to show that like we accept you as a patient and we love you and we want to give you the best form of treatment possible. So there's big changes that have been happening in medicine, especially now. Well, like one of my biggest things, if you talk to other physicians, like they were so used to just talking about HIV whenever they had a gay person or a bisexual person in front of them. And this was because of the HIV epidemic. But now that those conversations are changing, not from just HIV prevention, but to actual healthcare prevention or preventative needs in general. So I thought that was really cool. The last thing I'm going to kind of touch on before I'm going to let Dr. Roshni speak, because I don't want to take up all of the time, is just resources. So if you're on here and you're like, great, like I would love to be able to find out more resources So I can learn more about LGBTQ medicine, or if I have patients, where can I refer them, stuff like that. There's a couple, three main resources that I really like. One is the GLAMA website, and that's the Gay Lesbian Medical Association. They actually have a directory on there that you can like input your zip code into. And once you do that, it'll bring up all of the providers kind of nearest to you. So that's super helpful. And you can always like reach out to people and they'll help you find you a provider in the area. The Trevor Project is great. They have a couple pages. They do a lot of advocacy in general, but they have a great medical section with resources for all ages, for the elderly population, which is still a very valid population within the LGBTQ community that often does not get talked about. And I've done entire lectures about it, but have resources for them. They have resources for LGBTQ youth. So you're young, and excuse me, and you need help, and you need help finding medical care or just resources to help pay for medicine. And then they have a whole list of other resources, both nationally and locally. And then the third one is always the HRC, Human Rights Campaign. They have a great medical page as well that they can help you find other resources for as well. So like I said, the kind of big takeaway points that I would love for you to take away is, one, if you're a provider, do not be afraid to treat your LGBTQ people, okay? They're just like regular people. They have normal human bodies that need to be treated as well. If you're a patient and you're not comfortable with your provider, break down those barriers, present them with information that will help you receive the best care. Oftentimes, my patients will talk to me about like, oh, I feel like I should receive an anal pap smear. Let's talk about that. And I'll talk to them all about it. Or my transgender patients will, say like, oh, well, I heard like my friends were getting this done, or, this is a different standard of care. Let's talk about this. And we break it down and talk about their healthcare together. And it's more of a conversation. And it's not just a unidirectional from me being like, this is what we're going to do to treat you today. If that makes sense.
Okay, so yeah, I'm Roshni Patel here in Chicago. And then I was tasked to talk about where we've been and where we're heading in terms of PD research, treatment, and care in the LGBTQ community, which is a huge topic, but I'll just try to highlight a few things. So I wanted to just go over the big picture in terms of PD, although this was already touched on, I think, previously, but just in terms of like when we as neurologists see patients with Parkinson's, or see people with Parkinson's, we think about kind of where they are in terms of the disease course, and not everybody experiences all the different elements of these the symptoms that are shown here. And so I don't put this here to scare you, but I just wanted to go over all the breadth of things we can see when we're treating people with Parkinson's. So oftentimes people have non-motor symptoms, which many times precede the onset of motor symptoms, and they include things like constipation, sleep dysfunction, sometimes blood pressure and urinary problems, mood disorders like depression and anxiety. And then, of course, the classic motor features include things like slowness, stiffness, tremor, difficulty with walking and balance. And then, typically later on, we think of it as being kind of a later in the course, people can have issues with swallowing, cognition, sometimes hallucinations, things of that nature. So not everybody experiences all these things, but these are just some of the considerations in terms of the kind of the big picture of Parkinson's disease. And then in terms of treatments, again, just kind of a broad overview of Parkinson's treatments in general. We have medication treatments for these things. So we have medicines to treat the motor symptoms of Parkinson's, which classically, dopamine-based medicines such as levodopa is what we use. But we need to use sometimes medicines to treat the non-motor symptoms of Parkinson's, such as depression, anxiety, things of that nature. Exercise and rehabilitation is a key portion or a key part of the treatment of Parkinson's. So, and in fact, even though we don't have a cure or a disease modifying treatment in Parkinson's, some studies show that people who exercise more actually have a slower rate of Parkinson's progression. So exercise is really important and something we emphasize. And then we work sometimes with physical therapists, occupational therapists, and other folks in the rehabilitation arena to work on that. Sometimes patients need surgical or advanced treatments. So not everybody needs that, but some people may need that. And that can include things like deep brain stimulation, focused ultrasound. There's a procedure in which people can have continuous infusion of levodopa through the gut. So these are sort of like advanced or specialized treatments, which some people may need. Social engagement and stimulation. I recently added this to kind of this PD treatment summary slide that I've used in presentations before, because I think we're realizing the importance of this during the pandemic, especially when people have become more isolated and so this is important for everybody in general, but I think particular people with Parkinson's disease can be prone to having worsening of their motor and non-motor symptoms when they're isolated or lonely and things of that nature. So that's, I think, a really important part of the treatment. And then kind of multidisciplinary care. So, as a neurologist, I'm kind of focusing on certain things, but I work with other folks, folks like Dr. Estvold, the primary care doctor, and psychiatrist or psychologist, urologist, other medical specialties to treat other non-motor symptoms. So urologist if there are urinary symptoms, gastroenterologist if there's constipation, cardiologist if there's blood pressure issues, and lots of other kind of folks who are members of the team. So these are kind of broad overview of Parkinson's, how we treat Parkinson's disease in general. So what about Parkinson's disease care in the LGBTQ community? What do we know about it? The answer is not much. So if a year ago, if you went to PubMed, PubMed is our archive the biggest archive of medical research. So if you went to PubMed and if you typed in Parkinson's disease and the term sexual and gender minority, which is kind of the research term for LGBTQ, if you put those two terms in, then you would get 0 results a year ago. If you put those two terms in now, you will get 1 result, which is this paper that I've shown here. And so, and this paper was written by some colleagues of mine, and basically they are, in this paper, they're pointing out the lack of research in the movement disorders and in the Parkinson's community for LGBT folks. So really, unfortunately, there's not much formal research and there's not much formal data that we have about this, but that's changing. So let's talk about that, and let's talk about reasons for that and then how it's changing. So why is that? So there's lots of different reasons, kind of barriers to doing research about Parkinson's in the LGBTQ community, but I'll highlight a couple key reasons. The first is inconsistent data collection about sexual orientation and gendered identity, also known as SOGI, in our clinical, administrative, and research databases. So, for example, when you go to your appointment and you register for the first time at your institution, the person who's registering you usually collects your information about your name, your date of birth and age, your sex, which usually refers to legal sex. Oftentimes they collect information about race and ethnicity, and sometimes they collect other information about education and things of that nature. But until very recently, sexual orientation and gender identity information was not collected. In 2015, the Centers for Medicare and Medicaid, which is a big federal institution, they said, hey, people who have electronic medical records need to put a field in to collect, so that we can at least try to collect it. They didn't require that everybody has to collect it, but they require that people have to put a field in if anybody who has an electronic medical record, which is most institutions now use electronic medical records. They now have to have at least a field in where this data can be collected about sexual orientation and gender identity. So that was back in 2015 that requirement or that guideline was put into place. And so over the last few years, institutions have slowly been changing their electronic medical records and incorporating this field so that now we can at least start to try collecting this. However, it's not required. Because of that, it's collected inconsistently across institutions. So one institution might prioritize this and might train their staff to collect it, and so they might have very high rates of documenting this, and other institutions may, not even mention it to their staff, and so they don't, half the doctors there don't even know that this is something that they can put in the chart. So and in fact, that latter example was the case was the case at Rush when I was a fellow there. And so I did a small study when I was a fellow last year at Rush, where I wanted to just see what is the frequency of sexual orientation and gender identity collection in our movement disorders clinic. How frequently is that information documented in the chart? So I looked at all the patients that we saw in a 4-week period in our movement disorders clinic, and the frequencies are listed here. So 43% of the patients had sexual orientation documented, and 32% had gender identity documented in the fields. Interestingly, in most of those cases, that information was put in by the patient through the electronic patient portal. So in fact, most of the time, we as providers or as administrators were not collecting that information from the patients putting it in themselves. And then amongst those the patients who did, for which we did have that information, 4.5% of the patients in in our clinic identified as sexual and gender minorities. So that kind of reflects the prevalence of this of sexual and gender minority identity in general. And it kind of reinforces that it's an important thing. It's important information to collect, and it's information that people will probably be willing to share as long as we start collecting it more consistently. So this is improving. It's improving slowly. So now I work at the VA, and the VA is, of course, notoriously kind of slow to adopt things sometimes. But in fact, earlier this year, we now they now created sexual orientation and gender identity fields in our VA electronic medical record chart. So now we can, now we'll be able to start collecting that. So so I think things are changing, but they are of course a little bit slow to change. And in order to change this even more, I think more will be required, including, training staff and training providers about the importance of collecting this, figuring out what's the best way to collect it. Is it best for patients to just put it in themselves through sort of a indirect format, through an online portal, or is it best if the provider asks people? And so there's a lot of things to think about with this, but I think it's something that, hopefully there's forward more momentum with. Another issue that I will bring up is the lack of diversity in research and in terms of research subjects or participants in research. And so historically, this is probably true for most studies, medical studies or research clinical studies in general, but particularly amongst, it's kind of the big studies in Parkinson's disease. Historically, it's been kind of a very homogeneous population that has been studied. So typically mostly white patients and mostly men, and the distribution of men being out of proportion to the frequency of Parkinson's, because of course Parkinson's disease is more common in men than women, but typically in studies that distribution is exaggerated and men are even more so overrepresented. So this is a problem that people are recognizing, including, foundations and funding sources like Parkinson's Foundation, like the Michael J. Fox Foundation and other foundations who are funding research in Parkinson's disease. And in fact, now many of these funding agencies are now prioritizing studies that have plans for diverse recruitment. And so it's actually part of your research proposal is that you don't have to just include your inclusion criteria, what types of patients you want to include. You have to actually include a plan of how you're going to include diverse patients. So I think there is some effort now to improve this, but again, there's still a lot of work that can be done, including of course in Parkinson's research. So what are some issues that folks in the LGBT community may face who have Parkinson's disease? And I'm focusing here on LGBTQ patients with Parkinson's, not as much on caregivers, like how I think Zachary and Caitlin talked about that perspective. So I'm focusing here on like LGBTQ patients with Parkinson's. And so, because of the lack of research, of course, much of this is sort of just ideas and speculation about things that may be important, but we need to do a lot more work to understand these things better. But these are some of the things that I would think about and that I think that would be interesting to consider. One is motor and non-motor symptom burden in LGBTQ folks versus non-LGBTQ folks. So of course, in the non-PD literature, that some of which Dr. Estvold reviewed, we know that elderly patients have just elderly patients or elderly people in general who are quote sexual and gender minority patients or LGBTQ patients, they report higher rates of cognitive symptoms or cognitive impairment compared to non-SGM people. And so, since cognitive impairment is a part of Parkinson's and can be a non-motor symptom that can be very debilitating in Parkinson's, one wonders whether, the rates of cognitive impairment could be different amongst LGBTQ folks versus not. Some other considerations are, rates of anxiety, depression. We know in general, LGBTQ folks experience higher rates of anxiety, depression, and suicidality. And so, since of course these are very common non-motor symptoms of Parkinson's, one wonders could there be a difference, or maybe possibly higher rates amongst LGBTQ folks with Parkinson's. And then this has also already been alluded to. There's been some reports that there's higher rates of smoking and cardiovascular risk factors, especially amongst lesbians. And so in Parkinson's disease, when people who have higher vascular disease or vascular comorbidities or vascular risk factors tend to have worse motor and non-motor symptoms. So one wonders if particularly lesbians with Parkinson's disease, may they have higher rates of vascular disease, and could that correlate with clinical symptoms? So those are a few considerations. It's not all negative though. So another thing I was thinking about when I was putting this together is, could there be perhaps increased resilience and increased coping mechanisms amongst LGBTQ folks with Parkinson's disease? Because of all the barriers and the things that that we've overcome over the years and over our lives, and so in some ways could that be a protective factor that could maybe that could actually be a benefit for people with Parkinson's disease. In an effort to try to understand some of these things a little bit better, one study that I'm working on that it's kind of ongoing, we're still analyzing the data right now, so unfortunately I can't share any preliminary results, but we worked with the Fox Insights study, which is a study through the Michael J. Fox Foundation, and it's a survey study. So basically, people who enroll, that's people with Parkinson's disease and people without Parkinson's disease, and so really anybody can enroll, and you just enroll online. It's all done online, and basically periodically every 3 months or 6 months you get a survey about different in which they ask you about your motor symptoms, your non-motor symptoms, and different things related to Parkinson's. And so we put out a survey. Unfortunately, they did not collect any information about sexual orientation or gender identity when they put the study together. But we put out a survey last year where we actually asked participants about their sexual orientation and gender identity, and over 3,000 participants actually replied. And so now we're in the process of kind of cross-referencing that with the responses on the other surveys that those participants have done, including the motor and non-motor symptoms, to try to understand a little bit better, is there a difference, at least in this cohort, is there a difference between SGM, the sexual and gender minority, non-sexual and gender minority patients with Parkinson's in terms of motor and non-motor symptom burden, things of that nature. So that's underway. Hopefully we'll be able to report that and share that soon. Some other considerations, there's a lot of different things that we can discuss, and many things have been discussed already, but caregiver issues and advanced care planning. So in particular, folks in our community, we have different support system structures compared to others, right? So we may or may not be married to our partners. We may or may not have biological children or children at all. And so our support system and our support structures are look different. And so that's important to consider, when I'm, as a neurologist, when I'm taking care of people with Parkinson's disease, I follow them for years and I get to know them very well and their caregivers very well. And so it's important to kind of understand those relationships and not just assume kind of the quote heteronormative structure of, that the person has a spouse and kids and stuff. And so, and we often say like, our families are kind of our chosen family sometimes, where we consider close friends or partners as family, as opposed to spouses, parents, children, things of that nature. And so I think that's something that's important to keep in mind. And then also it's important to keep in mind in terms of documentation and legal issues. So for example, in some states, for example, the people will automatically assume your next of kin is your parents or your children, and in some cases you may, that may not be the case, and so you want to make sure that you have documentation, things like healthcare directives and advanced care planning documentation, where you actually outline and specify who is the person you want to make healthcare decisions for you, so on and so forth. Okay. And then the last thing I'll mention is long-term care facilities and senior care facilities. Sometimes people with Parkinson's, do end up kind of living in these type of places, and they are notoriously, they're kind of notoriously places that are kind of unwelcoming for diverse populations, including LGBTQ folks. And so because of fear of discrimination by staff or other issues, oftentimes people describe going back in the closet, not feeling comfortable talking about themselves or their partners or their life. And it can be challenging environments. And so, this is an area where I think there needs to be a lot of improvement. There are sort of individual things that are coming up. So for example, there is such a thing, there is this entity like LGBTQ+ friendly housing. So one example of that, I just put a screenshot of it up here. It's here in Chicago. We have a community-based organization called the Center on Halsted. And so they actually built the first LGBTQ kind of senior housing in Chicago. And that's the sole focus of the housing. And so I think that efforts like this are great, but I think that in order to make an impact, there needs to be probably more widespread training and kind of improvement amongst all long-term care facilities and senior living facilities in order to kind of make changes that are more widespread. So bottom lines, we don't know much about LGBTQ+ health in Parkinson's disease because we haven't done much research on this until very recently, and hopefully more will be coming out soon. And I think programs like this are just an indication that this is now something that we're recognizing as important. And so I think there'll be more. We'll learn more as we go, and then hopefully we'll learn more as we collect SOGI, sexual orientation and gender identity data more consistently, and we prioritize diverse recruitment for studies. And then some special considerations in Parkinson's care amongst the LGBTQ community may include things like, differences in motor and non-motor symptom burden, caregiver support system and structure, fostering inclusive environments and culture, especially in the long-term care facilities, and then hopefully trying to understand barriers to care and disparities more in the future as well.